Okay, now it's time to move to step 4. Now that you've ruled out malingering and factitious, substance use, and general medical condition, now we get down to the kind of the meat and potatoes of the differential diagnosis process, which is determining the specific primary disorder. So, what you'll want to do in being able to do that is you're going to be grouping or attempting to group your symptomology, at least in broad categories, as best you can. Um, Specifically, the ones that are kind of the symptoms that are kind of coming together and that are most prominent are the ones that you're looking for. Of course, all of the symptoms are important, but what are the ones that are starting to cluster together and are causing the most impairment in the person's functioning or distress to the patient? And that's usually how I ask it: is which of these symptoms is causing the most distress? That will help me kind of group and determine what's primary and what might be secondary diagnoses. So here we go. So some of the groups that you'll want to kind of mentally be lumping these symptoms in or writing them on your notes while you're speaking with a client: are they depressive symptoms? Um, are they anxious symptoms with worry? So depressive, they'd be mostly sad, not wanting to do things anymore, possibly suicidal ideation, kind of the sadness, right? Then we have anxiety, which is stress and worry. That would be kind of a way to think about that category. Mood swings. So all of a sudden, are there big shifts in mood? Are there highs and lows? Is there happiness and irritability? So that's kind of its own little category. Are there certain behavioral issues, either odd behaviors or behaviors that are violating the rights of others, such as aggressive behaviors, hurting other people, or even, like I said, odd behaviors, things that are uncharacteristic of the person? So writing down maybe strange or uncommon behavioral issues are important. That might even include behaviors that are more oriented towards certain developmental ranges. So behavioral issues might be that a child is fidgety and can't sit still and can't, remain in his classroom and do his homework. Those are kind of behavioral things. Conduct disorder: are they, hitting and beating up on other people? Another one is substance use, as we spoke about in the other video. Are there any substances involved? That would help us group that symptomology together. Are there relationships involved, or are the symptoms particular to relationships? That would be a grouping of symptoms that you'll want to know about. Then social: whether a person is participating in normal social activities, how they feel about socializing, or are the symptoms in these other categories, how is that impacting them socially? So kind of grouping their social interactions, whether it's work, school, academic, or school, obviously academics, family relationships, legal issues, anything that's kind of social environment related, you'll want to kind of document as well. And then finally, if there's any kind of strange, bizarre, or extreme sort of symptoms, those can include hallucinations, delusions, those type of symptomologies that are maybe strange way of thinking, grandiose ways of thinking. That's kind of its own little kind of group or cluster of categories. Other things that are kind of common that just even the words themselves can help you group them might be when people talk about trauma. We can start to group that into trauma categories. If there are compulsions or obsessions, we can kind of group those into their own categories because they are their own categories in the DSM. So those are some other ones. I couldn't fit them on this slide, but again, trauma symptoms. Um, what did I just say? Obsessions, compulsions, addictions, things like that. Also, sexuality, that is another category, like gender dysphoria, and there's all sorts of fetishes and other things that have to do with sexuality. So again, just as you're doing a clinical assessment, grouping things in categories or beginning beginning to group them will help you when it comes down to formulating the primary diagnoses. After you've grouped these diagnoses together, again, asking the client which of these symptoms are most distressing to you or happen most often will help you then differentiate between primary and secondary diagnoses. So use the differential trees or the differential tables to assist with decision making. Again, I'm going to try and kind of reproduce them in my own way without kind of copyright issues, doing kind of presentation for the broad disorder categories. However, if you're interested in purchasing the book by the APA, I believe it's entitled Differential Diagnoses Step by Step. They will give you all the differential diagnosis trees that you can go down. And essentially, it walks you through these 6 steps, but it does it in a way that it rules them out and gives you the possible suggestions for the diagnosis. Step number 5, broadly speaking, with the differential diagnosis steps, is to differentiate from adjustment disorders, which you ask yourself the question, or ask them the question, are the symptoms below the threshold of the disorder? And is it in response to a common psychosocial stressor or phase of life issue? So if a person or an individual is stressed after they start a new job, or they recently start school, or they have a big test coming up, or they've had a recent pregnancy, and so dads, moms, whatever, are struggling with a lack of sleep. They're kind of on edge with nerves. They're getting used to the routines and different life routines. That's not necessarily an anxiety disorder or even a depressive disorder until they meet certain criteria, and or until the kind of normal adaptation of those life issues or phase of life issues eventually pass. And I would say the vast majority will. However, there are some that we want to keep an eye on, such as postpartum depression and things like that, to where obviously we want to kind of keep a close eye. But nonetheless, if it might be due to a psychosocial stressor, they were recently in a car wreck, recently divorced, anything like that, we need to determine whether or not this is a pretty common response to a phase of life issue, or is it something more serious? Grief and loss is a particular one that we often come about. If it's been longer than 3 to 6 months, then we definitely probably are going to consider it, especially their level of impairment, that it's likely drifted into a mental health diagnosis, as opposed to natural kind of uncomplicated grief that normally we would experience after the death or loss of a loved one. And the final one, step 6, is to judge between whether it's a mental health disorder or no disorder at all. Meaning, let's not kind of superimpose or impose our judgment or bias over top of the client. If not every individual should qualify or does qualify for a diagnosis of a mental health disorder. So ask yourself, does the disturbance cause clinically significant distress in areas of life functioning? Or is the client describing that they're experiencing distress because of the symptoms? If they're not, then don't diagnose them. I've had plenty of people say that they've gone through traumatic experiences in their life, but they're not experiencing those symptoms currently. So it really wouldn't be appropriate to be, have a client tell you they suffered really extreme child abuse as a child, which obviously was significant and impacted them, but they're not describing those symptoms now in the here and now. They're not talking about flashbacks. They're not avoiding people and places, and it's not causing distress in the current kind of present atmosphere or present symptoms. Then that's what this step 6 is to say, is that unless it's causing the client distress or impacting multiple areas of their life, then it really is not appropriate to give them a diagnosis at all, really. So the DSM really doesn't set a firm rule about whether or not a person has or meets the clinical diagnosis or not. They leave it up to you as a clinician to use your clinical judgment in which you're considering the context, you're considering the person's culture, as well as your own personal bias and the patient's personal bias. And so you're trying to sort all that as well. And that's what we call clinical judgment, is to say, hey, given the sum total of everything you're seeing, is it within the norm? Is it expected? Does it rise to the level of meeting the DSM criteria, or doesn't it? All of those questions you need to ask, and eventually it's up to you as a clinician to determine, based on all of those considerations, whether or not it's truly a mental health disorder that they're suffering with or going through or have, or whether it's not, and it's something that maybe is provisional or needs to be ruled out eventually. Okay, that's the end of the differential diagnosis broad-based steps that you'll want to consider. There's 6 steps. Review this video to go through those 6 steps and understand kind of one by one of how you do a differential diagnosis and the things that you need to consider before finally putting that down on paper. Hopefully this was helpful, and we'll talk to you next time.